Good evening, Bala sir. Clearly here.
Dr. Solanki,
Yes, sir.
you are able to share the screen?
Should I start sharing, sir?
Just start sharing and see if you can share the screen and there are any technical problems.
Okay, sir.
Good evening, Dr. Subramanya.
Good evening, sir.
Priyali ma'am, Priyali Didi, good evening. Dr. Bala sir, good evening. And all the best, Dr. Preeti.
Good evening, good evening.
Thank you, sir.
Good evening.
Iti, is your this thing open on your screen?
Sir, ma'am, I am trying.
Yeah, now it's fine.
Yes, yes,
Move the slides.
right.
Next slide, Preeti.
Yes, ma'am.
Is it moving?
No, ma'am.
So click on this slide and then it will move.
Okay.
Yes, yes.
Great.
Everything is fine. You may stop sharing for a few minutes.
Okay, sir.
Welcome, Dr. Mrityunjay.
Sir, good evening, sir. Good evening.
Good evening. Good evening. Right.
Good evening, Subramaniam, sir. Good evening, Bala, sir.
Good evening, Mrityunjay.
Sir, good evening. Good evening, Madam. Kelly, Madam.
Bala sir, namaskar, Bala sir.
Namaskar, Madam.
Dr. Subramania, it is 9 o'clock. Shall we start?
Yeah, we will start.
Yes, yes, please.
Shall I go ahead, Ramakrishna sir?
Yes, 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 yes.
Okay. Dear viewers, all the faculties, greetings from Indian Academy of Pediatrics. And I bring personal greetings from myself and Dr. Upendra Kinjwadekar and Vinit Saxena and all the office bearers of IAP for PG Reach program. This would be a program where postgraduates are going to discuss, and we have got very interesting topic and yet common, but it is so common that it is at times more challenging than otherwise. And we have got a DM resident presenting the case, Dr. Solanki, guided by Dr. Piali Bhattacharya, who is a professor of pediatrics and vice president of South Zone IAP as
Central,
well.
Central.
And we have got Dr. Balasubramanian sir, Dr. Mrityunjay sir, Dr. Ramakrishna, Dr. Sara madam, who is going to join us, and Dr. Rawat. So greetings from all the teachers and wishing all the best for Preeti. I will hand it over to Dr. Ramakrishna. But one line from me that newborn may not appear yellow, but yet can have jaundice. So this is only one line from me. Except for that, I don't want to tell anything because I'm not a neonatologist, but all that I know is that the color of the skin is sometimes leading and at times misleading. So with these words, there is a whole lot of things that are going to unfold as the case moves on. When the jaundice would appear, how it progresses, which baby would get a jaundice, which baby would not get a jaundice, where it is supposed to be normal, or where it's supposed to be not ignored, where it is going to have short-term consequences, where it's going to have long-term consequences. All these things will be deliberated today. Over to Dr. Ramakrishna for further proceedings.
Right.
And we will be watching the flow of academics. Thank you, Dr. Ramakrishna. Over to you.
Right. Thank you, Dr. Subramania. I welcome all the viewers for going to be an excellent session to be moderated by the top class teachers. There is Dr. Balasubramanian, Dr. Piali Bhattacharya, Subramania, etc. Right. And a few words about our Didi, Dr. Piali Bhattacharya. And one need not introduce her because she is such a famous lady and very well known across the country. And she is in Sanjay Gandhi Institute of PMS Lucknow. And she is a dynamic lady. And she is presently Vice President Central Zone, Central IAP. And welcome, Dr. Preeti, and wish you all the best. Sure, we will be learning a lot from Dr. Piali and Dr. Preeti. And over to Dr. Piali to take over.
Thank you for those kind words, Dr. Ramakrishna. The case is a little long, so I will invite Preeti over to start the case without any delay. And let us discuss this case, thread it as it progresses. Preeti?
Yes, ma'am.
Can you
Thank you so
start
much, ma'am.
sharing? It's a long case, so we'll need a
The
little bit
voice
of
is
time.
breaking.
Is it visible, ma'am?
Yes, yes, visible.
Yes, Preeti, carry
You
on.
carry on, carry on. Perfect.
Good evening, everyone. Myself, Dr. Preeti Singh Solanki, DM Neonatology resident, second year from SGPGI, Lucknow. I will be presenting a case on neonatal jaundice. So this baby of X was a preterm 33 weeks plus 1 day baby. This was male baby and born at our center only. Mother was 31-year-old, gravida 8 mother. Mother's blood group is B negative and father's blood group was B positive. Starting with mother medical history. Mother is having bad obstetric history and is gravida 8. So in total, there were 4 spontaneous abortions in the mother with history of 1 intrauterine death with 1 expiry and 1 live birth. So gravida 1 was back in 2017. This was spontaneous conception and maximum pregnancies were unbooked and unsupervised. Blood group was not known in first issue, and under natal history, this fetus was antenatally diagnosed with hydrocephalus with spina bifida at 8 months of period of gestation. So labor was induced and mother delivered female baby. NTD was not given in first case. From gravida 2 to gravida 4, all pregnancies were unbooked and unsupervised, and spontaneous abortion occurred at around 8 to 10 weeks period of gestation. Dilatation and curettage was done. NTD was not given in gravida 2 and gravida 3, while it was given in gravida 4. Then in gravida 5, which was back in 2017, this was also spontaneous conception, unbooked and unsupervised. No antibody titer was done in mother. Spontaneous onset of preterm labor pains was there in mother. Female baby was delivered at around 8 months of gestation on the way to hospital. So poor follow-up was there for mother. Baby cried immediately after birth and was sent home. NTD was given in this pregnancy, but baby developed jaundice and seizures. So baby was admitted in hospital on day of life 1, but baby expired on day of life 3, and baby blood group was not known, and baby had not been investigated for this. Then gravida 6, which was in 2018, this was also unbooked and unsupervised pregnancy, and incomplete abortion was there. So dilatation and curettage was done. NTD was not given in this case also. In gravida 7, history of preterm labor pains was there in mother. So female baby was delivered vaginally at 8 months of gestation, but on day of life 3, baby developed jaundice. So baby was admitted in private hospital and exchange transfusion was done. Baby was discharged on day of life 5. This baby is alive and healthy and developmentally normal. So only 1 live issue mother is having, who is a female baby. So our index case is a product of gravida 8. In first trimester, there was no history of fever with rash, radiation exposure. There was no history of any drug intake like any anticonvulsant or warfarin or any other drug intake history. There was no history of bleeding per vaginum. There was no history. Mother did not take periconceptional folic acid, and no antibody titer was done in booking visit, which was outside our center. There was no history of swelling in mother in any areas. There was no history of alcohol abuse or any other substance abuse in the mother in first trimester. Under second trimester, there was no history of headache, feet swelling, or bleeding per vaginum. There was no history of blurring of vision or any documented hypertension. But mother had been diagnosed with gestational diabetes at around 24 weeks of gestation, and this was controlled on medical nutrition diet, and there was no need of any drug. Mother felt quickening from 5th month of period of gestation. In third trimester, there was no history of bleeding or leaking PV, and indirect Coombs test was done outside, which was negative at around 24 weeks of gestation, and scan of 28 weeks was suggestive of fetal ascites. So baby was referred to our center, and at our center, indirect Coombs test was positive, which was positive in titer of 1:16 at around 28 weeks of gestation. There was no history of bundle micturition or diarrhea in the mother, and there was no history of fever or rash in third trimester in mother. Baby was born out of non-consanguineous marriage. Total 6 antenatal visits were there. Mother received tetanus toxoid. Mother was dexamethasone covered, and under antenatal scan in our center, targeted scan was within normal limit, and fetal hydrops was there in form of fetal ascites and placentomegaly, and skin thickness more than 5 mm. And so Doppler study also ICT titer was positive in the ratio of 1:16. So Doppler was done, and it was indicative of severe fetal anemia. So mother was advised for intrauterine transfusion, and mother had history of receiving 3 intrauterine transfusions. Last transfusion was done at around 31 week, 3 days of gestation, that is 14 days before delivery of the baby. So baby was delivered spontaneously, and mode of delivery was vaginal with vertex presentation, and birth weight was 1984 grams. Baby was appropriate for gestational age. There was no history of meconium stained liquor. Apgar scores were 7, 8, 8 at 1, 5 and 10 minutes of age, and male baby was born. Placental weight was 680 grams, and under arterial blood gas analysis, cord pH was 7.4 and base deficit of 3.5. Then coming to delivery room management, baby cried immediately after birth. So delayed cord clamping was done. Initial steps were done as per National Resuscitation Program, as baby born was preterm. Injection vitamin K was given, but baby was having labored breathing in forms of subcostal and intercostal retractions, and grunt was also present. So delivery room CPAP with PEEP of 5 centimeter of water and FiO2 of 21% was started, and this FiO2 was increased to 25% as per target saturation ranges. Respiratory distress score, that is Silverman-Anderson score, for this preterm baby was 5 out of 10 at 10 minutes. So baby was shifted to NICU for respiratory distress, as well as a case of RH isoimmunization, which was diagnosed antenatally. So this is our baby X. So baby was admitted with presenting complaints of difficulty in breathing since birth, and yellowish discoloration of eyes as well as body after birth. Then history of presenting illness.
Generally, we shall not interfere before completion of history because you have such a long history. Shall we go quickly through the previous slides?
Sure, sir.
Right. From this first slide itself.
Okay.
Right. Group B negative and paternal is B positive. Right.
Yes.
Next, please. Okay. NTD was given only for some 2-3 pregnancies, is it?
Yes, sir. Only 2 pregnancies.
Do you recommend for admission every pregnancy?
Yes, sir. Sorry, sir.
Do you recommend NTD for every pregnancy or not? If so, why?
Sir, NTD is recommended if mother is having negative blood group, and at 28 weeks, if mother is having RH antibody titer negative, then only NTD is recommended. If it is RH positive, if it is antibodies are present, then no need to immunize, as mother is already isoimmunized.
Good.
And as NTD titer and as the NTD half-life is around 14 to 28 days, so we need to repeat it after the birth of the baby within 28 days of life.
Ideally to administer twice, one between 28-32 and other within 72 hours. Am I right?
Sir, ideally, sir, within 72 hours, and if not given, then it can be given till 28 days.
Right. We'll go. No, is it recommended for each and every pregnancy or not? That's my question, actually.
Sir, not for each and every pregnancy. If mother is negative and father is, sir, positive, and mother is having a negative antibody titer at 28 weeks period of gestation, then only it is recommended. And if after the birth of the baby is RH positive along with DCT negative, then only it is to be given after birth. Otherwise, no use.
Good. Next, we'll go to the next slide. There is nothing specific in this. Okay. Right. Yes. Next. So it's a disgrace for the various government programs that this lady has so many miscarriages, no antenatal care. Really, it's a disgrace for it. So dexamethasone was given how many times? How many doses?
So 4 doses were given, 6 mg, 12-hourly interval for 2 days, sir.
Which is ideal, betamethasone or dexamethasone?
Sir, both are equal in efficacy, but because of wide availability of dexamethasone, it is preferred in our setting. Also, sir, betamethasone is available in two forms, and it should be ideally given if both forms are available, and which is less readily available in our centers.
Because of lack of availability. Otherwise, we would have betamethasone.
Given
is
betamethasone.
superior.
Yes, sir.
Better than dexamethasone, but for want of availability, we are going with dexamethasone. Okay, wonderful that you have given 3 intrauterine transfusions. That's good. Right. Next. What will be the color of the amniotic fluid normally and in case of severe problem?
Sir, in case of normally amniotic fluid is clear, sir. There's no color; it's colorless. And in case of fetal distress, sir, because of meconium passage, it might be green or green colored, sir, green or dark green.
In severe isoimmunization associated with fetal distress. Only when
So
it is severe isoimmunization.
it might be yellow colored, sir, because of increased bilirubin.
Also, the card also can be yellow. Right.
Yes, sir.
Right. Okay. So this baby required registration after how many minutes? Within 10 minutes. Okay. Right. Next. Generally, such babies, you expect what? Acid-base imbalance immediately after birth with severe isoimmunization.
Sir,
Once you told it is
anticipated.
B positive and B negative, the diagnosis is clear. So what is the generally acid-base imbalance that is expected?
Sir, anticipated problems, these kind of baby might be having, first of all, as a fetal hypoxia might be there. So baby might be born with birth asphyxia. So we should be ready with that. Along with that, sir, a baby might be having severe respiratory distress because of respiratory distress syndrome, as well as because of pleural effusion and pericardial effusion. Baby will be having difficult ventilation. So we should be ready with catheters. Also, a baby might be having severe anemia. So we should be ready with O negative blood group. We should be cross-matched with mother's blood group
Right.
for partial exchange in case baby is having a severe anemia in delivery room itself.
Wonderful. You have to be prepared for birth asphyxia, severe pallor, that is anemia, and acid-base imbalance. And this is one scenario where you may have to give soda bicarb, which is not generally the case in majority of the scenarios because of severe acidosis. Okay, right. Next. It appeared on which what time? Instead of saying day one.
Sir, baby was under our care only, and we only attended delivery of this baby. So baby was having yellowish discoloration of sclera as well as a body up to chest immediately after delivery, sir. Within 1 hour of life, sir.
Is it usual? Appearance within 1 hour?
No, sir, it is not usual. Any jaundice present on day of life 1 is pathological, sir.
No, that is there. Within 1 hour, I'm asking. Within 1 hour is generally not usual because the placenta goes on clearing it. Generally,
Yes, sir.
it may appear around 6 hours.
Yes, sir.
That's
Yes,
what
sir.
I'm asking. No, I don't ask such a simple question. Whether it is pathological or physiological. So generally it is 6 hours, but it is within 1 hour. That means it's
Yes,
a
sir.
severe hyperbilirubinemia. Right.
Yes, sir.
Next. What are all the various causes of difficulty in breathing in such scenario?
Sir, most common cause, sir, in such kind of babies is birth asphyxia. If a baby is having delayed cry. Second, sir, because of pleural effusion, baby might be having difficult ventilation. Third, sir, respiratory distress syndrome. Because baby has been, baby will be, in most cases, baby will be delivered prematurely. Because of that, baby might be having respiratory distress syndrome. Also, sir, excessive pleural fluid and fluid in the inside the lungs deactivates surfactant. So such babies are more prone for respiratory distress syndrome in conjunction with prematurity and hemolytic disease of newborn.
Any cardiac cause?
Sir,
enumerated
anemia
nicely.
also, because of
Good
anemia
enough.
also, baby might be having difficulty in breathing because of defective oxygenation. Also, baby might be having congestive cardiac failure because of severe fetal hypoxia.
Very good, very good. Right? The child may have severe hypotension, congestive heart failure, that also may result in respiratory. So there can be so many causes and you have to make out and treat focusedly whichever is requires urgent treatment. instead of going simply in a broad way. Right. Wonderful.
Yes.
Yes, move on.
Yes.
Previously, so I think you have not covered.
Preeti, start presenting again.
Yes, right.
Ma'am, from first slide.
No,
No. Here, you start presenting again now. We've completed the previous ones. Now continue with your presentation.
ma'am is
Okay.
asking to go through this slide.
Okay. Under history of presenting illness, baby had respiratory distress in form of tachypnea and subcostal and intercostal retractions for which baby was given respiratory support in delivery room in form of CPAP. Baby also had yellowish discoloration of sclera and body up to chest after birth within 1 hour of life. There was no history of pale stools and color of urine was normal. There was no history of diaper staining.
Move on.
Sir, shall I continue?
Yes. Move on.
There was no history of lethargy in the baby. There was no history of bleeding from any side, no head swelling, no history of fever, excessive crying, abnormal movements, abdominal distension, or any umbilical discharge. Urine output and bowel output was normal for this baby. Under family history, there's a history of jaundice requiring exchange transfusion in sibling. However, there was no history of anemia, splenectomy, bile stones, or known heredity for hemolytic disorders in other family members. Baby received birth dose vaccine of BCG, hepatitis B, and OPV. Under social history, there are 5 members in the family. Mother, who is housewife and has done her education till intermediate. Father has its own
We'll
shop.
run through because nothing very specific. We'll run through.
Yes, sir.
Because we have to learn.
Family belongs to lower middle socio-economic.
Okay.
So, sir, under examination.
Just hold on. Dr. Piali, ma'am.
Yes, sir. Yes.
Your comment so far.
So, Preeti, 1 or 2 things you have to take family history, and I believe after that you've taken focused history as well. Not only family history, we need other histories as well. Have you taken any other history?
Ma'am, antenatal history complete I have taken, apart from mother's past medical history.
Correct.
And baby's negative history.
So which area does the child belong to? Because in certain areas, appearance of RH isoimmunization, I mean the geographic place, it is commoner.
Ma'am, baby was from Uttar Pradesh itself, from Ayodhya.
So in the northeast or northwest, is it commoner than in the rest of the country?
Ma'am, no.
And not only that, there is a history of IDM, diabetes mellitus, in this mother.
Yes,
So is the incidence of jaundice in IDMs more or is it less?
It is more, ma'am, because these kind of babies are having polycythemia usually. And so hyperbilirubinemia is more in these babies.
And what about the delayed cord clamping, as Dr. Ramakrishna was asking?
Yes, ma'am.
Delayed cord clamping.
Ma'am, earlier it was not recommended in case of Rh negative, especially isoimmunized babies, but it has been confirmed through several trials and study that, ma'am, delayed cord clamping is associated with 1/3 to 1/4 passage of blood in the neonate, and which results in decreased need of transfusion, exchange transfusion, as well as decreased need of further transfusion in the baby. So it is beneficial for the baby. So always delayed cord clamping should be attempted if resuscitation
norm.
is.
Yes.
Yes.
But in such
Yes, ma'am.
That we are
that with okay, the internet is playing a little. I
Yes,
said that with these children, due to delayed cord clamping, have polycythemia as well. And so that may add to the jaundice. Okay.
That will add, yes, ma'am. But it has been recommended, matlab, it is
Yes,
benefit versus
universally
risk.
recommended
Yes, ma'am.
that you do a delayed cord clamping at 2 minutes or so. So, but after 1 minute. But in these children, when you do a delayed cord clamping, it increases the polycythemia, which may result in an increased jaundice as well.
Yes.
Now, please continue.
Just hold on. Dr. Balasubramanian, sir.
I have one query and one comment. The query is, this fetus had ascites.
Yes, sir.
What are the causes of ascites? And what is the cause of ascites? That's my question
Sir,
to you.
in case of, sir,
Just wait. I have not completed. Just wait. One.
Yes, sir.
Two, you said that abdomen is not distended.
Yes, sir.
But you go back to the picture, I'm sure Dr. Piali will also agree with me, the abdomen is not normal, it is distended.
Go back to the child's picture.
Yeah, now tell me, is this abdomen, would you call it as not distended? I will ask Ramakrishna or Piali. That's my question.
Right.
Third question is, you use the term abdomen is distended or not. How do you decide and say anybody's abdomen is distended or not? What is the criteria to say an infant's abdomen is distended or not? 3 questions to you.
Yes, sir. Sir, first of all, pathophysiology of ascites in Rh negative isoimmunized baby.
No, causes. Don't worry about pathophysiology. Causes of fetal ascites and what is the cause in this infant? That's what I want you to tell me.
Okay.
Total differential diagnosis of fetal ascites and how do you identify the cause and what cause do you think contributed to fetal ascites in this infant?
Sir, first cause severe fetal anemia because of any reason. Sir, in this baby also, Rh negative isoimmunized baby, fetal anemia was there, which contributed to, sir, extramedullary hematopoiesis leading to hepatomegaly and splenomegaly, and hepatomegaly will result in liver dysfunction leading to hypoalbuminemia. So, sir, this will cause ascites as well as pleural and pericardial effusion might be there. Also, sir, because of severe fetal anemia, congestive cardiac failure might be there, or any other causes which cause congestive cardiac failure like congenital heart disease, or all causes of non-immune hydrops like thalassemia, and also these all diseases will lead to ascites.
Anything else? Anything else? Anything else? You know, I'm giving you a clue. I always have interest in infectious diseases.
Torch, sir. Because of hepatitis splenomegaly, all torch infection.
Which torch infection causes fetal ascites?
Sir, if liver dysfunction is there in any infection, then it can cause.
See, actually, you should only think of 2 common infections which produce fetal ascites: syphilis and parvovirus infection. Actually, CMV is not notorious in causing fetal ascites, nor toxoplasma, nor rubella. They all come with manifestations postnatally rather than with fetal ascites. Syphilis, congenital syphilis is very well known to cause fetal ascites, similar to parvovirus infection. Okay, right.
Yes.
Now you should answer my next question. How do you define abdominal distension? And you still agree with the picture here, whatever I'm seeing, the abdomen is distended or not? I leave it to the jury of Ramakrishna and Piyadi.
It is, sir. Right.
It is looking distended, Preeti, but then you will have to tell us, when do you say it is distended, or how do you say that it is distended
That's my
in any baby?
That's my undergraduate question.
Dr.
Yes,
Preeti, you see the flanks.
Sir,
The
yes,
flanks
sir.
are full, isn't it? Right. And
Sir, flank fullness, and along with sir, shiny abdomen, as well as sir, transverse umbilicus. All these points toward abdominal distension.
Shall I tell you? Shall I tell you?
Yes, sir.
More than all these criteria, the most objective way to define the presence or absence of abdominal distension is to put any baby flat, without the pillow or without the head end or leg end being raised. And like you look for precordial bulge, you look from the foot end and from the head end. If the abdomen is rising above the level of the chest, that abdomen is defined as distended. I hope you get a very fundamental point. You follow?
Yes, sir.
That is the most objective method of identifying abdominal distension. This abdomen is distended. In fact, it's not only distended, I see that the umbilicus is also pushed down. And you said there is fetal ascites, which wouldn't have disappeared, even if you had given exchange transfusion. I'm sure this baby has either organomegaly or ascites. That's my observation looking
The
at
baby was not having abdominal distension. This picture might be looking like that, sir.
No, that's not. See, I don't know. Okay, fine. There's no way I can prove or disprove what I'm saying. It looks like the abdomen is distended. Looks like one more thing, doctor. Is the position of the umbilicus normal?
No, sir.
I can make out transverse stretching. In fact, you can zoom the picture. I can make out the umbilicus is transversely stretched and the umbilicus certainly pushed down. It's not in the middle of the abdomen. I'm sure Dr. Piyali and Ramakrishna would agree.
See, Preeti, what sir is trying to impress upon you is that there are three things in clinical examination. The first being look, then listen, and then feel. So the look part is very, very important. The doorstep appearance, the first impression of how the abdomen is, like sir is saying, from the foot end or from the head end, you can see it rising above the level of the chest. That makes you say that yes, it could be distended. And then comes all the 3-4 points that you have said. And finally, the palpation part. So look, listen, and feel. Looks are very, very important.
Okay.
Ramakrishna, Dr. Ramakrishna, you are mute.
One more final question. Is this a preterm appropriate for date infant, or is this a preterm small for date or large for date?
Sir, appropriate for gestational age.
Okay. If it, how the weeks and the weight correlate is 1. You said weight is 1.86 or so.
1948, sir.
194. How many weeks?
1.9.
33 weeks.
33 weeks, 1.9.
That should be okay. That should be. Okay. What difference would it make for you if the infant is preterm and appropriate, and preterm and small for date?
So small for date babies have more complication than as compared to appropriate for gestational age babies, like metabolic disturbances, higher chances of hyperbilirubinemia requiring exchange, and hypocalcemia, and so respiratory distress syndrome also more in that baby.
Yeah.
And
it could have been the whole thing, the respiratory distress, instead of being due to cardiac failure, it could have been due to meconium aspiration if it is a small for date.
yes, sir.
Due to intrauterine hypoxia. Okay, thank you. Please go ahead.
Was there grunt?
Yes, sir.
Grunt was also there, right?
Yes,
sir.
grunt was there.
Right. Okay. Move on. No, you mentioned abdominal distension here.
No,
Dr. Preeti.
no history of, sir.
No,
Sir,
no,
these
no.
are all negative history.
Negative. Okay. Carry on.
Yes, sir.
Yes, move on. Okay, we'll go ahead. Yes.
Under examination, under vitals, baby was euthermic. Heart rate was in between 140 to 160 per minute, which was normal for this baby. Baby had tachypnea with respiratory rate of 68 per minute. Mean blood pressure was 38 millimeter of mercury, which was normal for this baby. Baby had normal perfusion in form of normal capillary refill time. Baby maintained saturation of 91% on room air, and there was no oxygen difference in preductal and postductal. Central pulse and peripheral pulse were well palpable, and baby was euglycemic with sugar of 144 milligram per DL. Under general examination, there was no facial dysmorphism. Edema in form of skin or edema or any scalp edema was absent. There was no facial puffiness. Pallor was absent, but icterus was present till chest. There was no cyanosis, no rash or ecchymosis. Anterior fontanelle was open and at level. There was no spine deformity, and no other obvious congenital anomaly was present.
What's your inference from vitals?
Yes, sir.
What's the inference? Anything you want to infer from vitals?
Sir, baby is having respiratory distress in form of tachypnea, and baby was also having grunt as well as retractions, subcostal gyphoid as well as lower chest retractions with Silverman-Anderson score of 5.
Not in significant hypotension. You're right.
Yes, sir. Baby was not having any sign of congestive cardiac failure, and baby was not having shock.
That's what. See, the expected scenarios can be safely excluded based on the vitals analysis. That's my point to tell. And you expect hypoglycemia?
Hypoglycemia might be there, sir, but
No,
baby
you
was
expect.
not
Okay.
having.
It's not a rule, you expect, isn't it? Just to
Yes, sir.
make people aware. And regarding general examination, what is a little discordant among the findings? You find any discordance? See,
Sir,
when the baby has icterus right from 1 hour of the birth,
yes, sir.
you expect pallor because how they are related.
Sir, because of increased destruction of RBCs, only
Yes,
bilirubin is
one
produced.
is called and another is effect. Hemolysis, severe pallor, and that results in significant icterus.
Yes, sir.
And usually it is 6 hours, rarely, but it is appeared in the first hour itself. But still,
Yes,
you
sir.
say that there was no pallor. The one
Yes.
cause can be your intermittent transfusions, but it was
Transfusion.
how many days prior to it? Prior
Yes,
to birth. The third
Yes, sir.
transfusion was how many days prior to birth?
Sir, around 10 to 12, 10 to 14 days, sir, prior to birth.
But reasoning says by this time the baby would have developed pallor, isn't it? With so much of icterus in the
Yes,
first.
sir. Sir, on
Generally
physical
it is
examination,
expected.
pallor was not there.
Okay, fine. Move on.
Sir, coming to systemic examination, under respiratory system, baby was having tachypnea on inspection, as well as chest retractions were present, both upper and lower chest, and subcostal retractions were also present. On auscultation, bilateral equal air entry was present along with conducted sounds. Under
better avoid the term bilateral equal air entry. You can be a little more specific, okay? Right, especially when there are abnormalities in the respiratory system. You didn't mention grunt was also there, okay?
Yes, sir. Audible grunt were there.
Was
Sir.
there,
Yes.
okay. And no tracheals, right?
Yes.
Because the baby had birth asphyxia, right? Okay.
Under cardiovascular system examination, precordium was normal, and on auscultation, S1, S2 was present, regular. There was no murmur, and there was no evidence of congestive cardiac failure like gallop rhythm or tachycardia. In para-abdomen examination, abdomen was soft, and liver was palpable 2 centimeters below right costal margin, which is normal for this age, and spleen was not palpable, and no other mass was palpable. Under cranial central nervous system examination, baby had normal consolable cry. Tone was both active and passive tone for this baby. Post-menstrual age was normal, and activity was fair. Posture was slight flexion with abduction. Anterior baby was symmetrically moving all 4 limbs with spontaneous eye movement, and anterior fontanelle was at level, size 1.5 by 1.1 centimeter, and neonatal reflexes like grasp, rooting, and sucking was present, and pupil was normal size and normally reacting.
So the one system primarily affected was respiratory, right?
Yes, sir.
All right. Okay.
So, I shall be discussing
Dr.
course in
Piali, ma'am.
analysis.
Dr. Piali, ma'am, any comments at this stage? Dr. Piali, ma'am.
Yes, yes, yes. So Preeti, in the delivery room, like you have received the baby, do we anticipate certain problems with this child?
Yes, ma'am. Already, ma'am, anticipated problems in this baby was we were expecting that baby might be having asphyxia as well as difficult ventilation, as a baby was having fetal ascites at around 28 weeks of gestation. So baby might be having pleural effusion or pericardial effusion. Along with that, because of fetal anemia, baby might be having features of congestive cardiac failure. So we were ready with all equipment which were needed for resuscitation of this baby, like catheters for drainage of pleural fluid if difficult ventilation will be there, and O negative blood cross matched with mother to be transfused for partial exchange in case of severe pallor is present in baby.
So basically, we had anticipated because of the prematurity. It is a 33-weeker, isn't it?
Yes, ma'am. Yes, ma'am.
And with this kind of an intrauterine transfusions and anemia and so many losses in the mother, that is why we believe that we expected number one, hypoglycemia because of a diabetic mother. So we would be prepared for that, for a bedside blood sugar test.
Yes, ma'am.
And then we should be prepared for correction of hypoglycemia. Number two, do you believe the posture of the child could have given you an important information?
Yes, ma'am. As this baby was preterm, and so baby might be limp if baby was having birth asphyxia, but this baby was having slight flexion with abduction in both upper and lower limbs.
Okay, fine. Please proceed. Bala sir, would you want to ask something?
No, straightforward. No, the only thing is, one comment I would say, I mean, with these findings, I wouldn't say that there is no evidence of cardiac failure. It's impossible for anybody to simply conclude just because there is no murmur, just because there is no gallop, just because there is no bulging precardium. In a neonate, such a young neonate, one cannot categorically say there is no cardiac failure when you have respiratory distress and hypoxia. That's my comment. And you must remember that, when the cardiac failure is of acute onset, you may not get hepatomegaly, you may not get gallop, you may not even get tachycardia.
Hepatomegaly was there, sir. So
Yeah,
that adds on.
2 centimeter, okay. That too with a background of fetal ascites, but with the transfusions. I mean, to dogmatically say that there is no cardiac failure, I would not agree at all. I would only keep my options open. Right?
Right, sir.
Where did they ask for crackles?
Sir, only, sir, hoarse, conducted sounds were present, but this resolved after 2 hours of life, sir.
Why did they ask for specifically look for crackles?
Sir, because of congestive cardiac failure, sir.
No. You are doing wonderfully all this 40 minutes. Crackles not in congestive heart failure, isn't it?
Sir, V's, okay. Sir, in congestive cardiac failure, sir, V's, basically in neonate, we are getting V's, sir.
No, see, why did I ask is whenever there is acute left ventricular failure, acute failure, it is the left ventricle that fails in acute conditions. When it is chronic condition, it's the right ventricle fails. So it is not that just because congestive cardiac failure is not there, it doesn't mean that there is no heart failure. There can be left ventricular failure, okay, because it's an acute event. For that, I asked whether there are any crackles in the base of the lungs.
Yes, sir.
Okay. Dr. Ramakrishna, one comment.
Yes, sir.
I didn't want to say that earlier. The term congestive cardiac failure is outdated.
Yes, sir.
It's no more used in cardiology books as well as textbooks. Previously, when we were all undergraduates, we were taught forward failure, backward failure, congestive heart failure, left ventricular failure. Today, it's only cardiac failure. There is no cardiac failure where the left is isolated from right and right is isolated from left.
What I'm saying, more of left.
Yeah. That is one. Second thing is, crackles are a very, very unimportant sign of cardiac
Yes, sir.
failure in pediatrics.
Right.
They're useless. If you ask me, crackles are a useless sign to diagnose cardiac failure. Where if I were to ask Dr. Preeti, which is the most single sensitive sign of cardiac failure? Two signs, only two signs.
Sir, tachycardia
Yeah,
and
second
gallop.
one? No, not
Gallop.
Tachycardia, right.
tachycardia and respiratory distress, tachypnea. That's all. All other criteria for cardiac failure may be there, may not be there in young infants, particularly in neonates. Gallop need not be there. Right? You may
Yes.
have tachycardia and tachypnea. They are the most important physical sign. Maybe third we can add cardiomegaly. And hepatomegaly is not a very reliable sign. Because any respiratory distress is going to push the liver down, and it's very difficult to appreciate in a sick baby the liver span and etc. Thank you.
Yes. Sir, shall I proceed?
Move on.
Sir, then course of baby in our NICU, a baby was shifted in delivery room after birth to preheated warmer, and delivery room CPAP was given. Then baby was shifted to NICU in view of respiratory distress in a transport incubator. In NICU, immediately CPAP was started with PEEP of 5 centimeter of water and FiO2 25%. Baby was nursed in radiant warmer with skin mode set at 36.5 degrees Celsius, and baby was immediately started on intensive phototherapy, and baby was also started on expressed breast milk through orogastric tube because baby was on intensive phototherapy, and baby was given EVM at 60 ml per kg per day.
What's the cord TSB? Is it?
Sir,
Less than
cord
expected?
TS, I have explained in other slides also, sir.
Yeah.
Cord TSB was 2.1 milligram per DL and hematocrit was 34%. So this was not the criteria for double volume exchange transfusion. So baby was continued on intensive phototherapy, and 4-hourly bilirubin monitoring was done, sir, along with hematocrit.
It is less than expected, isn't it?
Yes, sir.
Right.
Sir, intensive phototherapy in form of triple surface phototherapy was given. Sir, cord hematocrit was 34%, cord bilirubin was 2.1 milligram per DL, reticulocyte count was 0.8%, and diet Coombs test was negative. This can be expected in case of 3 intrauterine transfusions. And baby blood group is not reliable, so was not done. And calcium total was normal for this baby, but ionized was less. So baby was having early onset hypocalcemia, and hematocrit was also monitored 4-hourly, but this was normal, 45%, 51%, and 46%.
Which type of incompatibility the DAT or DCT can be either positive or negative? In case of RH incompatibility, but for the intervention, it shall be positive, but for the intervention. But there is one incompatibility, blood group incompatibility, where it can be either positive or negative. What is that?
Sir, OA incompatibility.
Right.
Sir, on day of life 2, under ventilation.
1 minute, Dr. Preeti.
Yes, sir.
What is the cord bilirubin level, which is the cutoff for starting phototherapy right on day 1 to any unit? At what level of cord bilirubin? Is there any cutoff of cord bilirubin?
Sir, on day of life, yes, sir.
Yeah.
Sir, on day of life 1, we are using normogram, sir. According to that, we have to start phototherapy. And if visible jaundice is present, sir, we are starting on day 1 itself.
At what cord
Yes,
bilirubin level? At what is the cut normal? What is the recommendation for
Sir,
starting phototherapy for a particular cord bilirubin level? That's my question. I don't know. I'm asking for you. I'm trying to learn from you.
yes, sir. Sir, this is the nomogram we are using. So, sir, at 0 hours of life, it's around, sir, 3 milligram per day, sir.
Then why did you start phototherapy for this baby?
Sir, baby was having clinical jaundice, sir, till chest. Sclera was also yellow, sir.
Okay.
Yes.
Fine.
And in view of, sir, bad obstructive
Once
history
there is,
and
no, you are right.
Clinical
Once there is
jaundice-
clinical
No, no.
jaundice,
I'm not sure. I'm not sure whether as a clinician, I would be able to appreciate jaundice in a baby whose bilirubin is 3.54.
sir, in
I-
view of bad
yeah.
obstructive history also and RH isoness pregnancy, as well as, sir, clinical jaundice was there in this baby till chest. So we started phototherapy, sir.
Okay, but with these levels, would you continue or would you stop? 3.54, 2.36, etc.
Sir, we are doing 4-hourly monitoring, and sir, when the phototherapy level
Obviously,
is,
well below the cutoff. Well below the cutoff. So
sir,
what are you doing?
till this age, sir.
Okay.
what
Matlab
other
we-
factor prompted you to go for phototherapy? Apart from a little less than expected range, what other factor has prompted you to go for phototherapy?
Sir,
Right.
mother is having bad obstructive history,
Power.
and sibling death is there, along with repeated abortions.
Yeah.
So these all are the factors which should guide us for
See, this
prompting
baby itself
early
is a
and
preterm baby. Preterm baby.
this is also a preterm baby. So risk factors are present.
See,
So all these
and there is
factors
probability of acidosis, birth asphyxia. All these things.
are risk factors for hyperbilirubinemia, causing brain injury, sir. So
See, this baby has many risk factors. Preterm,
yes, sir.
birth asphyxia, probably acidosis, right? Apart from the history which you have enumerated, right?
Yes, sir.
And clinical jaundice, very unusual. Jaundice in the first 1 hour itself speaks there is something severe hemolysis is going on, right? The only thing which is not explainable is not the absence of pallor. Okay, we'll see.
Yes, sir.
Go ahead.
But
Sir,
but I'm unable to accept that when you have clinical jaundice, the bilirubin levels are 2.36, 4.5,
Yes, yes,
and 2.54. Impossible for anybody to identify jaundice if the levels are correct.
The bilirubin assessment biochemically is not totally perfect. I think as you are very much aware, we will go by the clinical finding, right? Right.
sir, baby
Oh.
also had apnea. So IV caffeine loading was given and maintenance was also started. And as baby had ionized calcium less than normal level, so IV calcium was started for early onset hypocalcemia.
What was the cause for hypocalcemia in this?
Go
baby?
back, go back.
Sir, many risk factors are present in this baby. First is prematurity. Second is, sir, infant of diabetic mother. And
Yeah.
third, sir, Rh negative isonized baby liver dysfunction is present along with hypoalbuminemia. So this may be a contributing factor. The many risk factors are there for this baby.
Whenever you find a low calcium level, which other biochemical parameter you should always assess?
Sir, we have to look for albumin level as well as.
What is the albumin? What is the albumin in this baby?
Sir, albumin level was normal for this baby, sir.
Okay, that's very important. Before you start correcting,
And sir, we also have to look for blood gas, either acidosis or alkalosis. This also influences calcium level.
okay.
How can we explain the serum bilirubin not raising over 12 hours also?
Yes, sorry, sir.
Is there any explanation why the serum bilirubin is not raising? It
Sir,
appears
we have
12 hours, but at
continued
12 hours it is
intensive.
only
Yes,
It's
4
2.3.
hourly, sir.
4 is 3.56, at 12 hours 2.36.
Yes,
Just
sir.
phototherapy made so much of change, impact.
Intensive phototherapy, sir, we are
Even
giving.
then also, for pathological jaundice, even if it is intensive, the response may not be all that prompt. Dr. Pial,
Yes.
your comment.
Yes, sir. But this baby didn't require, sir, exchange transfusion.
Right. Okay, that's fine. But we would like to learn whether there is any other factor which has given such positive outcome of not going, not much of increase of bilirubin levels. Okay. Okay. Move on.
Sir, on day of life 3, baby was shifted to heated humidified high flow nasal cannula with flow 5 liter per minute, and FiO2 25% was continued, and IV maintenance caffeine was shifted to oral caffeine. And for hypocalcemia, as calcium level was normal, so calcium supplementation was stopped after 48 hours of life.
No, just can you go back once? Go back. Go back. Back previous day 2. See, you better mention some clinical findings on day 1, day 2, day 3, day 4, like that. I think you are not mentioning. Of course, labs are important, bilirubin assessment is important, but you have mentioned about something clinical findings, especially in the general examination. What was the change? Okay. Regarding the respiratory distress, like that. Okay.
Yes, sir.
There's some
Sir,
improvement. Whether the
respiratory distress of baby in.
grunt is improving, like that. See, first
Yes,
clinical and also labs.
Okay, sir.
Next.
Sir, on day of life 3, baby was only having a mild tachypnea.
That's it.
Respiratory rate was in between 56 to 64 per minute, while there were no retractions, no grunt. So baby was weaned off to HFNC and with flow 5 liter per minute, and FiO2 25% was given as per target saturation range, which we maintain in between 90 to 95%. And baby had no apnea, so IV maintenance caffeine was shifted to oral caffeine. And for hypocalcemia, baby had no symptoms of hypocalcemia, and also repeat calcium report was normal, so calcium supplementation was stopped after 48 hours of life.
What calcium supplementation did you give?
Sir, calcium phosphate in the ratio of 2:1 we are giving.
No, for acute correction, did you give IV?
Yes, sir. Sir, we are giving, sir, if symptoms were there, we would be giving 2 ml per kg bolus followed by 8 ml per kg per day. That is 80 mg per kg per day, 10% calcium gluconate IV. And in this baby, we gave 80 mg per kg per day IV supplementation of 10% calcium gluconate.
What is the precaution you should take whenever you give a calcium?
Sir, under cardiorespiratory monitoring, we should give. And
is there any antibiotic about which you will be scared of when you give calcium?
Sir, local, sir. Thrombophlebitis might be there.
Ceftriaxone, if combined with calcium solution, can kill the child.
Ceftriaxone, sir.
Ceftriaxone. You can go to the net and see reports of deaths due to combining ceftriaxone with calcium. It's a dangerous combination which can kill. Thank you.
Yeah. Sir, what
precaution to
what is the sir basic behind that? Matlab ceftriaxone with calcium.
I believe it precipitates calcium and causes sudden cardiac death.
Okay, thank you. Sir, course from day of life 4 to 26 day of life under ventilation as tachypnea settled. So baby was gradually weaned off from HFNC to room air in 48 hours, and baby was on room air for 20 days before discharge. For apnea of prematurity, no fresh apnea episode occurred after day of life 10. So caffeine was stopped after on day of life 19. And under nutrition, baby was gradually shifted from orogastric feed to cutlery spoon feed with fortification, and then baby was taking direct breastfeed.
Okay.
So this is the status.
Before discharging the baby, we will have opinion of other panelists. Dr. Mrityunjay Das, any inputs you would like to give? Dr. Mrityunjay Das.
Yes, sir.
Any inputs you would like to give?
Sir, regarding the babies, actually, I wanted to know how Dr. Preeti, how could you know the fetal anemia from the Doppler study? And what was the dose of the transfusion?
Yes, sir. Sir, for under Doppler, sir, we have to know MCS, sir, middle cerebral artery peak systolic velocity. Sir, this is assessed mainly in the mid parietal, biparietal level. Sir, under this, when fetal anemia is present, as brain sparing effect is there, so diastolic flow will be decreased and systolic flow will be increased. This will lead to increased systolic velocity, sir. So higher the peak systolic velocity, higher will be the degree of fetal anemia. So sir, medial cerebral artery peak systolic velocity more than 1.5 multiples of median will indicate that fetus is having severe anemia, and it guides therapy like intrauterine transfusion.
So when do you subject the child? When do you think to go
Yes,
for
sir.
this study, to go for this Doppler study? What
Sir,
are the indications?
there is a protocol for antenatally diagnosed Rh negative mothers. Protocol is, sir, till 20 weeks of life, we have to get ICT titer, and critical ICT titer is, sir, 1:32, and
Okay,
positive
okay.
ICT titer is 1:16. So we have to serially monitor, sir, MCA peak systolic
So
velocity.
how much transfusion you need to give?
Sir, this is decided on the basis of, sir, peak systolic velocity as well as, sir, hematocrit also, sir. So, sir,
So how to know hematocrit from this middle cerebral artery flow?
Fetal hematocrit, sir. This is calculated on the basis of fetus hematocrit.
Okay, so how much transfusion you have given in this child?
Sir, 3 transfusions.
I am telling about the volume of transfusion.
Sir, exact volume, sir.
He
And
won't be
sir-
able to tell you, Dr. Mrityunjay,
yes.
because it is done by the high-risk maternity group. Dr. Mandakini does it. So these
Okay,
pediatricians are not involved in it.
Because it is antenatal done, so therefore we could not.
Yes, the gynecologists do it.
Usually. Okay, madam. Thank you, Dr. Preeti. Nice presentation and nice case. Really
Yes,
wonderful and answered very well to all the panelist answer, especially Bala sir and Ramakrishna sir questions. So nice, sir. So thank you, sir. Thank you for giving me the opportunity to stay here.
Right. Welcome, sir. Dr. Preeti,
Yes,
see,
sir.
actually the focus has shifted from hyperbilirubinemia to management of other complications. What
Yes.
made the bilirubin not to rise in this baby? Factor 1, 2, 3.
Sir,
Actually,
first
it's a case
factor,
of hyperbilirubinemia. Pathological jaundice appearing in first 1 hour. Still, it has not increased and cleared within 24 hours or 36 hours. See, what
Yes, sir.
made the change?
Sir,
Actually, we are
first of all-
forgetting about the hyperbilirubinemia. What could be the cause?
Sir, first of all, baby had received antenatally 3 intrauterine transfusion.
Got it. But the third transfusion is just 2 weeks prior to the delivery.
Yes, sir.
That is a very
And
long time. And there is no
yes,
pallor despite jaundice, and the bilirubin was not increasing.
yes, sir.
It will be
Second,
little
sir,
paradoxical.
because of intensive phototherapy, which we gave, second factor. And third factor, sir, baby was now not having other risk factors like birth asphyxia, sepsis, which might predispose baby to.
There is preterm, there is some birth asphyxia, there is respiratory distress. All these things are risk factors. No, I'm not questioning why it has happened. I'm just inquiring whether you have any explanation, either you or Dr. Piali. Because you are just forgetting to be a case of RH isoimmunization after first 24 hours, isn't it?
Yes, sir. So this baby did not require exchange, and
Okay, that's wonderful. But why? Any
therapy
cause
was being
you
done
can
within 48
attribute to,
hours.
right? Okay, move on.
Very simple explanation, Preeti, why this baby did not develop hyperbilirubinemia later. It's not, I don't think I will put I'll give the credit to phototherapy. It is because you had given 3 transfusions antenatal.
Yes, sir. Intrauterine transfusion. First
They
reason is that
have
only, sir.
their half-life would have taken care of the
Yes, sir.
antibodies going and hitting them.
But 2 weeks prior, sir. That is 2 weeks prior.
No. They have given 3 transfusions.
But still
And
2 weeks prior.
The last was about 10 days old.
10 days, is it? Okay.
Mm.
And the baby had hyperbilirubinemia, perceptible jaundice in the first 1 hour itself. Anyway, things happen, but I think it is not much comprehensible. Okay. We go with your statement. You need not show the slide, Dr. Preeti. Yes.
The transfusions must have taken care of the risk of hyperbilirubinemia in the postnatal period. 3 transfusions. But they would have been, those RBCs would have survived at least for 4 to 6 weeks. I don't know what is the timing of the last transfusion before delivery. If it had been close to delivery, I'm sure it would have taken care of the risk of hyperbulimia developing postnatal.
Apart from intrauterine transfusions, what else can bring down the problem of RH isoimmunization?
Sir, other therapies apart from intensive
not therapy. Any other clinical scenario which is coexisting with RH incompatibility can decrease the risk of isoimmunization.
ABO incompatibility with RH
Wonderful.
isoimmunization, sir,
Why?
decreases.
Wonderful answer. Why?
Sir, because in mothers having ABO incompatibility along with RH negative, sir, RBCs are already destroyed, sir. So lesser chance
because of
sir, RH negative and ABO, sir.
Because
ABO
of antibodies, IgM antibodies that are already
present, sir. So they destroy. Yes,
they
sir.
destroy the cells.
So yes, sir. So
there
they prevent
less chance of going for
immunization.
RH
Yes,
isoimmunization.
sir. RH isoimmunization. Yes, sir.
Good. Yes.
Sir, status of baby on discharge. Baby was 26 days old, post-menstrual age 36 weeks plus 6 days. Weight at discharge was 2,886 grams, which lied in 10 centile of Penton's chart, and length was in between 10 to 15 centile. Head circumference was in the 15 centile exactly. And baby was accepting and tolerating breastfeed ad lib. There was no episode of hypoglycemia which was documented in this baby. Baby was vaccinated with bird dose vaccination, and baby was discharged on supplements of D3, folate and calcium phosphate, and ROP screen was done, and it was normal. That is, bilateral zone 3 was vascularized normally. Hearing screen was bilaterally passed, and baby had passed pulse oximetry screening as well. Bilirubin at discharge was 0.98, which was negligible, and hematocrit was 29.8%.
May I invite Dr. Pragya? If you want to contribute, you may contribute. Dr. Pragya. Dr. Pragya, you are with us? Okay. Okay, Dr. Preeti.
So
You can stop sharing.
No, she has not completed.
One slide left, ma'am.
Okay.
So working diagnosis of my case is 33 week plus 1 day preterm baby, male. Birth weight was 1984 grams, which was appropriate for gestational age, with RH negative isoimmunized pregnancy, with neonatal hyperbilirubinemia, with respiratory distress syndrome, with infant of diabetic mother, and asymptomatic hypocalcemia with apnea of prematurity.
So comprehensive diagnosis you have put forward. Good. The clinical diagnosis should be always comprehensive. Right. Good.
Yes, sir. Thank you, sir. Thank
Anything
you,
else? Anything else? It's over, PPT. Any other slides are there?
Sir, I had added readmissions, but because you said that only presentation and diagnosis needed. So
Or out of curiosity, we'll go through.
okay, sir.
Continue then, Preeti. The time is up, I think. But continue.
Time is permitting.
Yeah, PRI madam, your comments on this case, your comments and your expert comments are required.
Sir, this case actually, we had anticipated a few problems in this case, and therefore we were ready for the outcomes. What was a little jinx in this case is that the bilirubin levels did not climb as high as anticipated, because we had even expected, if we were preparing even for a kernicterus in this case. So the presentation on the first day, first hour, and with the arise, and with this kind of a history, antenatal history of bad obstetrics. So we had expected even kernicterus, but the hypoglycemia, the kernicterus, all these things, we did not have to combat them actually. And the apnea also responded beautifully to CPAP. So the other problems, of course, the metabolic problems, the acidosis, they also responded well as the respiratory distress was managed. Generally, we do not get this kind of a smooth sailing in such patients.
That's what exactly I'm wondering. right?
Yes. Generally, we do not have so much of smooth sailing. But then one thing which I would like to impress upon is that we must realize that we must suspect some amount of hemolysis, and that for the students actually there are a few tips, like we must see what the hematocrit is like. If it is 45%, I had a child in which the hematocrit went till 77, and we had to do a partial exchange in that child. So suspect hemolysis when the hematocrit is rising. If it is, or if it is sort of abnormal blood smear, if you find spherocytes or an abnormal blood smear, if you've done it at a bedside with a heel prick, and of course, if the reti count, that is also very significant. It is in the 72 hours, 72 hours. If you find a reti count of 4.5% or so, then of course, signs of hemolysis must be looked into. And the severity, like Bala sir was saying, the severity will be predicted by the cord blood. And so cord blood hemoglobin is one significant factor which needs to be looked into. If it is less than 10 gram per DL, then cord bilirubin greater than 5 milligram. In this case, the cord bilirubin was also not that much. And then, of course, in siblings, if there had been further history, if we could have checked for any kernicterus or erythroblastosis in those siblings, but we didn't have that kind of a history. And as I said, prematurity was a contributing factor over here. So I believe all the problems that arose were more of prematurity rather than of isoimmunization.
Right.
Thank you. Thank you.
Dr. Pragya is there? Dr. Pragya. Okay. You may go on with your presentation because we have time.
Preeti,
Yes, sir.
you can show all the further slides that we had
Because
prepared.
out of curiosity, we'll be knowing what has gone further.
Please go further on to the slide of diagnosis and then continue from there. So there were readmissions.
So there were two admissions. First, on day of life 40 with severe pallor, hematocrit was 16.9%, but there were no signs of congestive cardiac failure in this hematocrit also. And 1 unit PRBC calculated according to the weight of the baby was transfused, and baby was discharged at hematocrit of 25.4%. And baby was again readmitted on day of life 74 with severe pallor. Hematocrit was 13%. Still, baby had no signs of heart failure. Ma'am, slides are visible?
Yes.
Okay.
Visible, and you are
And
audible.
at this, as baby was having severe pallor, so partial volume exchange transfusion was done in this admission, and baby was discharged at hematocrit of 31.6%.
Just 1 minute.
Yes.
Shall we go back? See, now you will tell the various causes for delayed appearance of pallor for enlightening everyone.
Yes, sir. First of all, sir, because of intrauterine transfusion, hyperbilirubinemia would be not that much requiring exchange, but it is one of the important cause of early as well as late onset anemia, sir. So basically 3 types of anemia these babies are having. First of all, early hemolytic anemia because of increased destruction of RBCs, which this baby was not having within 14 days of life. Second, sir, late onset hemolytic anemia after 2 weeks of life, sir. This baby was having this type of anemia, and in this case, sir, retic count increases, and also hyperbilirubinemia might be present. And this baby was also having, sir, a late hyporegenerative type of anemia, that is because of erythropoietin deficiency in these kind of babies. Because of intrauterine transfusion, erythropoietin levels are decreased, which leads to bone marrow suppression, leading to late onset anemia. In this case, reticulocyte count is below normal level, which was in this baby. Reticulocyte count decreased, and so baby was having late onset anemia.
What else can be there apart from anemia in this scenario?
Sir,
Apart from
other,
anemia, other cell lines?
apart from anemia, sir, thrombocytopenia, leukopenia can also be
Good,
there because
good,
of bone
good.
marrow
Because it is
suppression. But
suppression.
this baby
It's
was not having, sir.
Right, right. This
Only
baby is a blessed baby. She is not having many complications despite basic.
yes, sir.
Right.
Hematocrit was transfused, the PRBC was transfused, and baby was growing well. And
The antibodies may be still persisting at low levels that may also cause some anemia over time, right?
yes, sir. That
Right.
is hemolytic anemia and late onset hyporegenerative anemia if anemia occurs beyond 2 months of life. But this resolves by 3 to 4 months of life.
Right. What else is paradoxic in this slide, in readmissions rather?
Sir, congestive cardiac failure was not there.
There, even with hematocrit of 6.9, even 13%, not having heart failure in a neonate is really surprising.
Yes, sir.
Yeah.
So that's why we did partial volume exchange transfusion because a severe anemia was there, thinking that might lead to cardiac failure, sir.
Okay, but not having cardiac failure itself is also a enigma. Right. Next. No, for this only I wanted you to go for the next readmissions. Right, we will be learning some more points. Next, anything else?
This is done. So rest, I had slides about pathophysiology.
You may
It's
quickly
not
go through
required,
by
Master.
10 minutes.
No, I don't think theory is required.
No, 5
Yes, sir.
minutes, yes, sir. Because she made so much of effort. Just 5 minutes, important slides.
Sir, this was the article, sir. In this, they found that transient hyperinsulinemia and hypoglycemia in Rh isoimmunization is associated with pancreatic islet cell hyperplasia, sir. This is called as mesidoblastosis. So, sir, hypoglycemia is common in Rh isoimmunized baby apart from risk factor like prematurity. So, hypoglycemia should also be looked in this kind of baby because of islet cell hyperplasia in pancreas.
Right.
Apart from that, sir, theory part is there.
Now, just enlighten everyone what is triple surface
Apart from, sir,
phototherapy.
yes, sir,
What is
triple surface
double surface, triple surface. Just you enlighten. For average postgraduate, right?
Sir, under surface phototherapy, which we can provide through a belly blanket or an under surface LED lights are also there, and two over surface phototherapy, sir, LED or fluorescent lamps can be used, sir.
Right.
Apart from, sir, phototherapy and exchange transfusion, role of IVIG, sir, that can be given 0.5 to 1 gram per kg, which can be repeated after 12 hours, but data on efficacy is conflicting and it is not recommended nowadays, but it can be considered if exchange is not feasible immediately. So IVIG is not recommended, but if there is delay in exchange or exchange is not possible in center, like in periphery, then it can be considered. So mechanism of action is blocking FC receptor of macrophages, leading to decreased destruction of RBCs. So fourth alternative, earlier used like albumin, phenobarbital, clofibrate, and metalloporphyrins are not recommended now. So this should not be used. Sir, prebiotics are under trial, sir. These are thought to increase gastrointestinal motility and stool frequency, so they can improve feed tolerance and growth of beneficial bacteria in the gut. So, sir, these increases enterohepatic circulation and decreases bilirubin in the preterm neonates, sir. So, these are under trial, sir. So, this trial is from 2016, and these are still under trial, sir. Prebiotics. Also, sir, antenatal steroid in various trials, it has been recommended that betamethasone reduces the risk of neonatal jaundice requiring phototherapy, possibly because of acceleration of liver maturation, sir. So antenatal steroids are also effective in these kind of babies, sir. So these should be recommended in all preterm pregnancies. Sir, as already said, sir, intrauterine transfusion increased risk of postnatal anemia. So this might be the reason that this baby required third admission also for transfusion. But this resolves by 3rd month of life. The role of delayed cord clamping is there in red blood cell aluminization, as it increases rate of transfusion as well as degree of hyperbilirubinemia. Apart from that, sir, other pharmacotherapeutic options, if anemia is persisting, these may be erythropoietin, folate, vitamin B12 supplementation, which we are regularly supplementing in these babies. And iron should not be administered in these babies in the first 3 months of life, because they are already overloaded with iron because of repeated transfusion. So iron supplementation should be avoided in these babies. Sir, in this study, long-term neurodevelopmental outcome after intrauterine transfusion was studied, and it was primary outcome was incidence of neurodevelopmental impairment like cerebral palsy, severe developmental delay, bilateral deafness, or blindness. And it was concluded that intrauterine transfusion decreases the risk of these neurodevelopmental impairments. So its incidence was found only 4.8% in treatment group.
What are the goals of your treatment in ROH immunization? What are the goals?
Sir, first goal is prevention of, sir, hyperbilirubinemia, which can cause neurological damage leading to neurodevelopmental impairment.
No, there are two different things. One is neurotoxicity, other is neurodevelopmental outcome.
Impairment.
And
Yes,
the more impairment. The first one is more important, immediate.
Yes, sir. Immediate and later.
No,
yes.
These two.
Long-term
There is
outcome.
another factor, that is severe anemia and resultant hypoxia. That also has deleterious effect on the brain. Okay. These are the
Yes.
three goals.
Sir, so take-home messages: detailed antenatal history with identification of cause of hydrop should be done, and capable an ICU team and a tertiary center should be there. Anticipation of preterm delivery and respiratory distress syndrome should always be done, and delayed cord clamping should be routinely done. Early intensive phototherapy along with exchange as per age-specific cutoff norms should be advocated, and regular follow-up hemoglobin hematocrit for anemia in RH isoimmunized babies should be done even after discharge of the baby. Thank you.
Wonderfully done. Dr. D.M. Gupta, your inputs. Dr. Gupta ji, your inputs.
Very good evening. Thanks for inviting me, sir. I was just late.
Please stop
joined it.
sharing, please.
Okay, ma'am.
Right.
I have just came to know the last few slides only.
Okay.
Mm.
Right. Right. Dr. Preeti, you have done a wonderful presentation and you were presenting very good, very fast. And I am sure you will never allow the examiner to open his mouth. Your presentation is so fast. I always tell my PGs to present in such a way that reverend spade, it should be like that, so that the examiner will not have time to interrupt. And despite all this, we interrupted you frequently. I am a little unhappy, but to bring out some subject from you, we have to interpret. We are forced to interrupt, not to cause obstruction. Otherwise, people will not be knowing more and more points.
Thank you so much, sir.
Really,
I am also obliged to be there in such platform with you all. Thank you so much.
Your presentation is very good, exemplary, and I wish you all the best. And Dr. Piali, you have groomed up her well, and your mentoring is very good. And I need to tell about Dr. Balasubramanian in every session. It is always excellent. Right?
But Bala sir has pointed out a few very important things which Preeti must have learned from him.
Yes, ma'am.
So, yeah, Preeti, keep that in mind also. Bala sir is one of the doyens. So, if he has actually told you about ascites, so remember, ascites,
Yes,
examining the flanks, examining the abdomen for a distension. These are the few points that you have to be very particular while doing a clinical examination. Thank you, Bala sir, for that.
After
Thank you so
I am
much.
asking, there is yet another age period where you have to differentiate whether it is really abdominal distension or just protuberant abdomen.
Yes.
How to differentiate? At what age it can be physiological? A little protuberant abdomen. How to know whether it is physiological or because of any intra-abdominal disease? What is the age period it can be? There can be abdominal distension physiologically. Of course, you are a neonatologist. You need not answer it. Anyway, I'll tell because you are
in fancy, protuberant abdomen is normal, but we should always look out if umbilical hernia is there, so as to rule out other.
Not that way. Because you are into neonatology, I shouldn't have asked you. In second year of life, there will be protuberant abdomen. That is not because of any disease. It is physiological because there will be lordosis. Once you make the child lie down, the distension goes. There is another scenario in rickets. then also there is protuberant abdomen, nothing wrong with intra-abdominal structures. Once you make the child lie down, that distension is not seen. Okay? Right.
Okay, sir. Thank you so much.
Excellent presentation by Dr. Preeti. I learned a lot. It was fantastic. My compliments to you. Keep it up. All the best.
Right.
Thank
Exemplary.
you so much, sir.
I for the resident, for the first time, I'm thinking whether you should be given another chance. Right.
Thank you so much, sir.
You really have done wonderfully. Exemplary. Right. Anything else, Dr. Das, you want to add?
Excellent, Dr. Preeti. Really, congratulations.
Thank you
Really
so
great presentations, and especially Bala sir and Ramkrishna sir, PLE madam. PLE madam especially groomed her very well. So I hope Preeti will be the great neonatologist of our country, going to be. So really, it's a wonderful thing and wonderful learning also for all of us. So thank you, and thank you, Ramkrishna sir, for this wonderful evening, academic
Welcome,
evening.
sir.
So
You are
Preeti is very lucky. She has had very good teachers, in the form of Dr. Kirti, Dr. Anita. Dr. Anita
Okay.
was supposed to be here. So the professors in neonatology are excellent. So she's getting very good teaching.
Yes,
No,
sir.
ma'am,
Yes,
ma'am, you should have invited them to be a panelist. In the
I did, but there is some NAC inspection and everything. So they are very, very busy also. I did ask them to come in.
Fine. Dr. Bala, sir, any final words from you?
Nothing. Well done, Dr. Piali. Thank you very much. I enjoyed listening
Right.
to it.
Dr. Piali, any final words and message?
Dr. Pyali ma'am,
Ji?
DM Gupta is here.
हाँ,
No,
DM,
we
hello,
know.
बोलिए.
Ma'am, this Preeti Solanki is the same guy who has PG from KGMC or from Allahabad? I think.
Preeti, introduce yourself, Preeti.
I have done, sir, my MD pediatrics from Allahabad Medical College,
Yeah,
MLN Medical
yeah.
College. I met you in a conference, sir. And that time also I presented posters, sir, and you were judging that. Yes, sir.
I know you because you have presented the poster in my
Yes, sir.
during my tenure as a secretary.
Yes, sir. Yes, sir. Yes.
2017-18.
Yes, sir. And I got first prize, sir. You were judging
Yeah.
that. Sir.
Naturally, that you need not tell. Right.
Mm.
Right.
Yes.
Dr. Piali, ma'am, your
Best wishes.
final
Solanki.
words.
Thank you so much, sir.
Final
That's it,
words.
sir. We will remember that, as Bala sir said, it is always look, listen, and feel. A doorstep examination or a look at the child should be revealing in many ways. So for an RH-ICU immunization, there are several histories which are also very important in any neonate with jaundice, including the family history and the antenatal history. So the history part should not be missed when you are examining a child with icterus neonatorum. And the appearance of jaundice in other siblings or sibling deaths or a history of hydrops or stillbirths, things like that will guide you in such cases. And then, of course, be ready for management in the labor room. If you've not done a neonatal resuscitation course, I think all the residents should undergo a neonatal resuscitation program so that they are very ready and apt to be the skilled pediatrician for such children. And remember that Bhagwan chappar फाड़ के देता है जब दुख देता है तो, so the mother will have a lot of bad obstetric history, a mother will have diabetes mellitus, a mother may have SLE along with, so you can expect a lot of issues which will come in. So build a team. That is my message to the residents. You should have a team together who will be helping hands to you when the need arises. You cannot play God alone.
Yeah, anticipate the problems. That is also very important, rightly told. Because this baby, blissfully, she had smooth sailing, but many problems are anticipated in such scenario, right?
Sir, I must say, Preeti and Dr. Kirti and everybody attended to my grandchild who was born on last 22nd, yes, last 22nd. And he had RDS. He was 36 weeker, just a 36 weeker with a low birth weight. And the child had RDS. He was put on CPAP and went on further to be given an exchange transfusion by these residents only. So I'm very grateful to Preeti and everybody for that baby that they gave back to me, hale and hearty. He's now 1 month old.
First, congratulations, ma'am.
Thank you.
Then
Thank you so
some-
much.
Right,
Thank you, thank you, thank you.
right. We'll call it a day, right?
Yeah.
And Dr. Piyali, ma'am, thank you very much for joining and enlightening us. And Dr. Preeti, wish you a wonderful career. All the best. Good night.
Thank you so
Dr.
much, sir.
Good night,
Guptaji,
sir. Good night.
Piyali, ma'am, Preeti, Dr. Mrityunjay Das. Good night.
Good
Good
night,
night,
sir.
sir.
Good night to
Good
all
Thank
of
you,
you.
sir.
Good night.